Thank you for having us today. If you can pronounce your name for me, Perea.
My name?
Yes.
Perla. Perla.
Oh, Perla, Perla.
Yeah,
Okay,
yeah,
Perla. Thank you. Thank you so
yeah,
much for having us today. I'm
yeah.
Crystal Lee. I am with AuthoraCare Collective, and we are a serious illness care provider. I am the community outreach and resource coordinator for our organization. That means I traverse 13 counties to share our resources, to connect with faith leaders, to connect with community-based organizations, to connect with the community at large, to share what we do in our serious illness care space. I have served in outreach in various capacities for over 20 years. I have been with AuthoraCare Collective for 2 of those years, and I enjoy the work that I'm doing connecting with the community. So I'm going to have Cheryl introduce herself as well, and then we'll get started.
Hi there, I'm Cheryl Wink, and I know my name on there duplicates Crystal Lee, so please just bear with us here. My name is Cheryl, and I am a community liaison for AuthoraCare Collective, meaning I go through the counties of Chatham, Orange, and Durham counties at this time, and I share the services that we offer to those at medical practices and in senior living communities. My history has typically been in the senior housing industry and in one capacity or another. And I have been with AuthoraCare for 3 years now in this role.
Wonderful. So I'm going to pull up our presentation. Give me 1 second to do that. There we go. Okay. And we're going to share more about how we serve patients, families, and caregivers. Okay, great. Can you all see that okay?
Yes, ma'am.
Okay,
Looks great.
great, great. Okay, so AuthoraCare Collective. First of all, how many by a show of hands have heard of AuthoraCare Collective before today? All right. Well, we were formerly Hospice of Greensboro and Hospice of Alamance Caswell. And so with that, we have been in this space of caring for those who are seriously ill for about 45 years. The two agencies came together about 6 years ago to form AuthoraCare Collective. And at this point, we have expanded our service line tremendously. We are beyond palliative care and hospice. And so we're going to share today what those services look like and how, if you all know someone who may need our support, can connect to our organization. So we meet people where they are in their healthcare journey, no matter where they are with that. We support them and their families and support the caregivers. I like to read our mission statement because it resonates so well with me when I read it, and I like to just put those words in the atmosphere for you all to get an understanding of who we are. AuthoraCare Collective empowers people to be active participants on their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. And when we say that, we mean that we do support people in their minds, in their bodies, in their physical well-being, and in their spirits with our chaplain program for those who would like that kind of service. We'll say that people often ask, how did we come about the name AuthoraCare? And we have that name because we honor the patient as the author of their life story. So we help them to create moments that matter, during a terminal or a critical illness. We help their families to sometimes access other services like respite care in some of our programs. And we're there in a supportive role to make sure the patient has a good experience as far as receiving the health care that they need. So no matter where the patient is in their care journey, we support patients, caregivers, and families. I'm going to walk through really quickly some of the categories of care that we provide or have in our service line. And so, of course, hospice and palliative care, we'll talk about those items in more detail in just a moment. We also, in certain counties, have a Kids Path program. Those are primarily offered in Guilford County and west of Guilford County. But if you know someone in our catchment area that may need support for a child who is grieving or a child who has a critical illness, we are there for those families. We're going to talk a little further as well about our expanded value-based care services. That would be GUIDE, which is a dementia care program. And Cheryl's going to share more about that program as well. We also offer grief counseling for the community and for our patients and families and caregivers. That would be in the form of adult grief counseling and children's grief counseling. Initially, we were primarily focused on grief support and grief counseling because of the nature of our work in hospice and palliative care. However, we have now expanded counseling to include any life challenge. So anyone can receive those services. And when we talk about funding innovation, AuthoraCare has a foundation where we do garner funds throughout the year to support those who may not be able to afford certain types of care. We often say we support people regardless of their ability to pay for services. And then we also have a thrift store in Burlington. If you're ever in that area, exit 145, that also supports and funds some of our care for those who may not be able to pay for services. So whose lives do we touch? We're going to go a little more in depth about some of our service programs now, and Cheryl is going to talk to you about our dementia care program. Sorry, I got ahead of myself. I'm going to talk about the palliative care program. So, when we look at palliative care versus hospice care, we like to frame this as a continuum. A healthy person, a person with an illness, a person with a terminal illness, and then ultimately death. So, a person who is healthy, of course, is going to their primary care physician. They are focused on preventing illnesses, making sure they're caring for their physical being. A person with any stage of illness, maybe an onset of a minor illness, of course, would seek curative care to cause that illness to dissipate or no longer have that illness. And then those with a critical or a serious illness could be an illness like a COPD or cancer or renal failure, any kind of a serious debilitating illness would come to us for palliative care. And that is a supportive and consultative service. And then, of course, we have hospice care for those who have a terminal illness. So, what is palliative care? Often we have questions from the community about the differentiation or the differences between palliative care and hospice care. So, palliative care, again, is more supportive, it's more consultative. Um, People with a serious illness get support in managing their symptoms, setting a care plan, kind of choosing what kind of care they want, and relieving those symptoms. It's very supportive in that it can serve as a bridge between the primary care physician or the medical team and the patient and their caregiver, kind of bridging that communication gap if there's one, checking on the patient more frequently in case there are any problems that appear in between their visits to their doctor, just making sure they have that extra layer of support. Now, it is billed differently from hospice in that it's billed as a fee for service, so there may be a copay with that service. But also, again, we are committed to providing support for those who may not have the ability to pay for services. And that can vary by one's insurance plan. And I am going to go through this part. I believe I left out Cheryl's part, but I'll go through this and then we'll talk about dementia care. So, let's see, where am I? Let's go back here. Okay. So our hospice program is for those who have a terminal illness. In that care, the doctor certifies that if the disease progresses as it normally would, the patient would expire in about 6 months. So for that program, we accept Medicare, Medicaid, TRICARE, other insurance plans to make sure the patient has the care that they need towards the end of life. And one thing that we do as well out in the community is community presentations about our services, letting people know about advanced care planning, letting people start or helping them to start conversations about hospice and what that might look like, even if they have no illness, but kind of easing that conversation and letting people begin to talk about what end of life may look like. So anyone can make a hospice referral. An order from a physician is needed to admit the patient to hospice. We admit them as soon as possible. And one distinction in the hospice program is that the patient is no longer receiving curative treatment. They are focused more on quality of life and quality of care, spending time with their families. Um, they're no longer seeking, for instance, radiation or chemotherapy, those types of treatments for a cure. So again, we have a healthy person who receives preventative care. We have a person who may have a minor illness for curative care. For a serious illness, we have palliative care, and then we have hospice for those who have a terminal illness, are no longer seeking a cure. They want to focus on quality of life, and we always give people hope in saying it's not giving up. It's just getting another layer of support. So here's a chart that kind of talks or speaks to the differences between palliative care and hospice. You see the prognosis there, 6 months or less for hospice. In hospice care, we assume full risk for the care of the patient, assuming full risk for making sure they have durable medical equipment and other support, whereas palliative care is more consultative, taking on the responsibility for symptom management. In hospice, we have an interdisciplinary team model, meaning that we have several professionals and experts who are managing the care for the patient. And whereas in hospice, a person is receiving comfort care as opposed to aggressive treatment or comfort care. And in the hospice model, the patient is certified for 90 days and then again for another 90 days. And after that, they can be recertified for 60 days at a time. So in that process, the care team is reviewing the prognosis. If the disease progresses at a normal pace, will the patient expire within 6 months? So we often have patients who um, continue to live beyond 6 months, beyond a year, beyond a few years. We have some patients who do graduate from hospice back into palliative care. So again, we always like to give hope and say it's not giving up, it's just receiving another layer of care. So our interdisciplinary team will look like this. And I'm going to stop for a moment. I have my gallery minimized. Are there any questions so far? I don't see any
I,
hands raised.
I don't see any questions in the chat either. I think people are waiting till the end to ask questions.
Okay, all right, thank you.
Mm-hmm.
So our interdisciplinary team would include, of course, a physician, a nurse, certified aides, CNAs, and homemakers, volunteers, a social work team rather, a spiritual counselor if the patient does choose to have a chaplain involved in their services, and then also counseling. Um, if a patient does happen to expire in our care, we offer 13 months of counseling within their Medicare coverage for the family to receive that extra support. And so I'm going to stop sharing here. If you'll give me a moment to locate my other slide, and then we'll take questions as well right here if you need to ask a question. Okay, so
Does anybody
okay,
have any questions?
and give me just a second.
Okay.
Okay, I apologize for that. Here we are. I think I mistakenly hid that slide. So we're back here to the dementia care program. And Cheryl, if you would
Okay.
like to talk about that.
So our guide program is,
Sorry. Could you put this line in presentation mode?
Okay, I thought it was. Let's see.
Not the way okay. Sorry, Cheryl.
that's okay.
Oh, somebody said they see it fine, so it might be me.
Oh, let's
Okay.
try this. Is it in presentation mode?
Yes.
Okay, great. There we are.
Okay. So We have partnered with the Centers for Medicare and Medicaid to offer this guide program that they came up with 2 years ago. It's an 8-year pilot program. So being the fact that it's a pilot program means that it's going through changes over those years. And we are really just kind of a vessel to get to the community for anyone that has any level of cognitive impairment. So in that box, it says that to qualify for the guide program, you have to have a diagnosis of dementia, but that can be any level of cognitive impairment. The other requirement is that the patient is enrolled in traditional Medicare, which is Medicare A and B. At this time, they are not accepting any Medicare Advantage plans. So that is kind of the stickler point that we've come across. But they've structured the program that way. So it's the cognitive impairment and the traditional Medicare. They cannot be enrolled in a hospice level of care, and nor can they participate in the PACE program. Now that we are starting year 3 of our guide program, we can have patients that are in independent living and a home setting. So that excludes any long-term skilled nursing home. It excludes someone in a memory care community or an assisted living. So the benefit really comes to those that are on their own and can also help support those caregivers as well. So there's a couple different components to the guide program. One of it is they're given a guide care navigator, and that person checks in monthly with the patient and the caregivers. It really is someone who is like a care manager. So they can answer any questions with their illness or what steps may be coming, things to get in order. They're really there to help support during the stages of dementia or cognitive impairment. The other level of that is upon evaluation to enter the program, you may be given respite hours. Someone can receive up to 72 hours of respite services, meaning we have partnered with various home care companies, and then the family will set up that additional support with those home care companies to have care brought into the home to relieve some of that stress that is put on that caregiver. The next slide. I guess that's my only slide. It is a pretty easily to understand program, and it's very simple. There is not a doctor recommendation or an order that's needed. We have information on our website. I am out in the community, and you can call me directly or email me directly of anybody that you think could benefit in some additional support on their journey with cognitive impairment. But we're very happy and proud to be able to service this population directly and offer more support.
Okay, thank you so much. And we're almost done here. I'm going to wrap up with our community outreach and education. I alluded to that earlier, how we are in the community, deeply in the community, sharing what we do, connecting people to resources, I am the Community Outreach and Resource Coordinator, and we have 9 community liaisons covering certain parts of our territory, of our region, um, to talk with clinicians and doctors' offices and long-term care administrators and just share more about our services and enroll people into services. As we are out building community, of course, we are building relationships and building partnerships. We have informal and formal partners. We consider anyone in the healthcare space who is working in alignment with our mission to be a partner, whether it's a one-time kind of event or collaboration or something that's more ongoing. We always welcome organizations and leaders who are doing the work that we are doing and how we can help support each other. We often coordinate community education, meaning that um, organizations contact us to come and speak about various topics, which could be advanced care planning or caregiver support. Um, what's another topic that's a hot topic, rather? Dementia care is one that we have quite frequently, or just to understand more about hospice and palliative care and the services that we offer. We're always open to go into the community, go into churches and faith-based organizations and share what we do. And then also a large part of our outreach is in the veteran community. We have a level 5 rating with the We Honor Veterans Initiative, which is a partnership between the Alliance for Home Care and the VA, Veterans Administration. So we have that highest designation because of the exceptional care that we provide to our veteran community. We partner with Veterans Bridge Home to offer veterans coffees in our area. And so we're always proud to be involved in that work. We have been a part of and are still a part of veteran stand down events throughout the 13 county region. I did share in the beginning that we have our main offices in Greensboro, Burlington, and High Point, but we also cover all of these counties listed here. And sometimes the services may vary slightly between counties depending on where they are, but we offer serious illness care across this 13 county region.
I also
Our
just
tax,
I also
yes.
just wanted to add that we also have inpatient units. I don't know if I missed that.
No,
Um,
go ahead.
we have inpatient units in Greensboro and in Burlington, very accessible right off the highway. And those are mainly used for, they're not long-term stay independent, inpatient units. It's more to stabilize someone and to offer that versus going to the hospital. Oftentimes, when there's hospital stays, there's a regression in their care, in their state of mind. And so by offering this small mini hospital of ours, of our inpatient units, um, it's more of it's an easier transition, and they stabilize and then they go back to where they call home. Um, And then also they can be used for um, the remaining, if there's typically under a week uh, that someone prefers to go there for their final days versus stay in their home.
Yes, thank you for adding that. And I did want to add one more point here about our palliative care in the Durham, uh, Chatham, Orange County area is through virtual visits. We still provide that exceptional level of palliative care and that bridge between the doctor and the patient and the caregivers. But those services in Durham, Chatham, and Orange are virtual. And so still reach out if you feel someone could benefit from that service.
The only exception maybe is if they live in a senior living community. So we have some patients under palliative that are in whether it's a memory care, assisted living, and we do have a palliative nurse that does stop in there. But everything else out in the community is virtual.
I'm going to give you a moment to jot down or record our contact information that's here, and then after that, I'll close this presentation out so we can answer questions. To make a referral, anyone can do that. Any community member can do that. Any organization can do that. Referral at AuthoraCare.org. Phone is 336-621-7575. And from that, we contact the patient or caregiver and the physician for additional information. And then here's Cheryl's name and title, contact information, and mine as well. And I'll give you a moment to record that, and then we'll take questions.